So good morning, everybody. It's a pleasure to introduce you Shahad Kasemi. She's a second-year resident with us, and she will talk today about abdominal compartment syndrome. So enjoy.
Thank you, Stefan, for the kind introduction. So today I'm going to tell you something about the abdominal compartment syndrome. And I'm going to give you a quick overview of what we're going to talk about. First of all, I'm going to start with some definitions, then continue with risk factors, the etiologies, pathophysiology. Then we come to the diagnosis, how we manage this, the prognosis, and then in the end to the conclusion. So first of all, I'm going to start with the definition. The abdominal compartment syndrome occurs when there is an intra-abdominal pressure which is elevated over 20 millimeters mercury, and it is associated with a new organ dysfunction or even failure. It can be with an APP, which is the abdominal perfusion pressure below 60 millimeters mercury. But we come later to this point, and there are different types that can be primary, it can be secondary, and even recurrent. So the abdominal perfusion pressure, it's a pressure which indicates the visceral perfusion. It's calculated by the intra-abdominal pressure minus the mean arterial pressure. The optimal range would be between 50 and 60 millimeters mercury, and maintaining it appears to be associated with improved outcomes. A low APP predicts the necessity of surgical decompression, but the World Society of Abdominal Compartment Syndrome made that there is no account concerning its use as a resuscitative endpoint, since the mean arterial pressure even elevated due to increased systemic vascular resistance, even though cardiac output is low. Thus, hypoperfusion may even occur despite acceptable APP. There are different grading systems. When the pressure in the abdomen is increased, we talk about intra-abdominal hypertension. There are 4 grades of this. Grade 1 is from 12 to 15 millimeters mercury, grade 2, 16 to 20, grade 3, 21 to 25, and grade 4 is about over 25 millimeters mercury. And for grade 4, there's the greatest incidence of organ failure, which typically affects heart, lungs, and kidneys. One has to say that the normal intra-abdominal pressure is about 0 to 5 millimeters mercury, and in critical ill patients, it's already elevated to 5 to 7 millimeters mercury. In obese patients, it's normally also higher, until even 12 to 40, over 40 millimeters mercury, and it's basically also physiologically increased in pregnant women. Exactly. So now we come to the risk factors that are, for instance, increased intra-abdominal volume by either intraluminal content or increased extraluminal content, or it can be also due to decreased abdominal compliance. Abdominal wall compliance is basically the elasticity of abdominal wall and diaphragm. It can be also due to a combination of both. It can be due to combination capillary leak and also fluid resuscitation. In ICU patients, the main risk factors are mechanical ventilation, ARDS, and fluid resuscitation. ALCS can develop basically in all ICU patients. Even 35% of ventilated patients were found to have intra-abdominal hypertension or ACS. In a multi-center observational study from 2004 where 13 ICUs, 6 countries with about 97 patients were evaluated. Intra-abdominal hypertension was found in about 50%, and ACS in 8% of all ICU patients even. So the etiology, as we already stated, there are primary ACS, which can be conditions associated with an injury or a disease that is originated from the abdominal pelvic region. For example, trauma or hemorrhage, bleeding, massive bleedings. It can be due to ileus by dilated loops. It can be secondary that do not directly originate from the abdominal pelvic region, for example, due to burns or massive fluid resuscitation over 3 liters of volume. It can be recurrent due to conditions in which ACS redevelops following previous surgical or medical treatment of primary or secondary ACS. So now we come to the pathophysiology. In general, bleeding, trauma, and abscesses lead to a physiological response of inflammation and swelling, which leads to an increase of intra-abdominal tension and therefore leads to hypertension in the abdomen. Due to intestinal obstruction, there will be dilated loops, which lead to compressive symptoms in the abdomen. Increased intra-abdominal pressure may begin to involve other organ systems as well. For example, the heart, there will be decreased cardiac filling and cardiac output, and increased central venous pressure due to inferior vena and portal vein compression, which will lead to an increase in systemic vascular resistance and therefore lead to hypotension. Due to the compression of the lungs, due to the elevated diaphragm, we will have reduced lung compliance, functional residual capacity, tidal volumes, and elevated air pressures, atelectasis, reduced capillary intrapulmonary shunt increases, and then therefore we will have hypoxemia and hypercapnia. One of the first signs may be anuria or even also lower urine output due to the compression of the renal artery and venous blood flow to the kidneys. We will have reduced renal perfusion, which will therefore lead to reduced GFR and low urine output. Oliguria may occur if there is a IAP of over 15 millimeters mercury, anuria if it's over 30 millimeters mercury. The decreased renal perfusion will lead to ischemia, and this may also contribute to acute renal failure, which will then need renal replacement therapy. And also neurologic symptoms may occur due to inferior vena cava compression, since it will lead to an elevated CVP and therefore lead to increased intracranial pressure and then a decrease in cerebral perfusion pressure. So all in all, the diminished venous drainage may consequently cause intestinal and mesenteric vascular venous congestion, ischemia, and edema, which will then result in a vicious cycle that increases IAP, creating IAH, intra-abdominal hypertension, and further development of ACS. The diagnosis. So first of all, we need to identify the different risk factors that may lead to the ACS. The World Society of Abdominal Compartment Syndrome recommends to screen for IAH and ACS when 2 or more risk factors are present. And if elevated, intra-abdominal pressure should be monitored every 4 to 6 hours. So, the physical exam, you may find there increased abdominal girth, tense abdomen, cyanosis, wheezing, or difficulty in breathing, but that's quite not sensitive enough because you can have these symptoms basically in other diseases as well. We can use imaging modalities, but it's neither sensitive nor specific for that. We can just maybe find a cause that will lead to that, but not the definite diagnosis that there is hypertension. The most conclusive one is measurement, which can be direct or indirect. This is the most accurate manner to confirm the diagnosis and should be measured when any known risk of intra-abdominal hypertension is present. So direct would be, for example, by pressure transducers by the root of the peritoneum. Indirect can be by stomach, by intragastric catheter, but the most commonly used one is the transbladder technique that's used. So the transbladder technique, one has to first say that the pressure in the bladder itself is already 1 to 3 millimeters mercury higher than in the abdomen. And it can be inaccurate if the patient is not sedated or lying flat. And the measurement should be taken at end expiration and in complete supine position. It's lower than 5 millimeters mercury in a healthy person. and over 25 millimeters mercury is suspicious for abdominal compartment syndrome. There are certain contraindications for this, which are bladder trauma, neurogenic bladder, BPH, and pelvic hematoma. And if we have this diagnosed, there is also a management algorithm, which is defined by the World Society of Abdominal Compartment Syndrome. And this is basically just to have a quick overview that there are these algorithms, and one can also take this as a help for the diagnosis and the management. And just to have this quickly revised, there are 5 important steps to be memorized. So one should evacuate the intraluminal contents by, for example, nasogastric or rectal decompression, empty the abdominal and or retroperitoneal extraluminal contents by percutaneous drainage, for example, to improve the abdomen and also improve the abdominal wall compliance by sedation and analgesia. And of course, optimize the fluid administration. One should have a balanced resuscitation and also maybe use vasopressors. And one thing that is very important to indicate early surgical intervention. So the gold standard for surgical decompression is the decompressive median xiphopubic laparotomy, which is a vertical full thickness midline incision through all the layers of the abdominal wall from the xiphoid process to the pubic symphysis. Early surgical intervention resulted in about 80% fewer complications, and it can be made either on the ICU or in the OR. For the laparotomy afterwards, we would aim for the open abdomen treatment. We will do the temporary abdominal closure by negative pressure wound therapy. And this contributes to some advantages of this procedure since it will have appropriate evacuation of ascites, which is rich on pro-inflammatory markers and contamination. It may improve the nursing care and also contribute to earlier fascial closure rates. And complications may be, of course, it's an open abdomen, it can lead to infections, fluid loss, anterior cutaneous fistula formation, or even ventral hernias. The re-exploration should not take longer than 24 to 48 hours after the index operation, and the optimal pressure of the negative wound therapy would be about minus 125 millimeters mercury, and lower levels of, for example, minus 70 millimeters mercury should be aimed when there is a suspicion of active bleeding due to coagulopathy is suspected. So the definitive fascial closure is the fascia-to-fascia closure. It should be attempted within 4 to 7 days after the index operation, and as a recommended strategy for both trauma and non-trauma patients. In non-infectious post-traumatic and non-traumatic hemorrhage, it's achievable about 75 to 100%. In abdominal sepsis, the primary closure is possible in only about 50% of the cases. Delaying a primary fascial closure over 7 days poses significant risk of increased complications, as we already heard, for example, the loss of soft tissue coverage, lateralization of the fascia, malnutrition, and formation of enteric fistula. And there are different surgical reconstruction techniques that may facilitate the definitive closure. For example, by anterior or posterior component separation, using prosthetic mesh traction by sublay meshes, which have low recurrence for hernias, or use a split thickness graft on the visceral surface with a planned delayed definitive closure. The prognosis, left untreated or having a delayed treatment for ACS can be fatal because it has very high mortality rates. It can lead to multi-organ failure, which can lead to delay of the recovery for weeks or even months due to prolonged need for mechanical ventilation and dialysis, and many other reasons. This is basically the chart which will show you how high the prevalence and the mortality rates are. In IAH grade 1, it's only about 10 to 25%, while in ACS, it can be even up to 90%. So a quick recap of what we already heard. The measurement of IAP bears a significant prognostic value. IAH and ACS are frequently associated with a poor outcome. Early and ongoing assessment, including serial IAP measurements, should be monitored in any patient with a suspicion of IAH or ACS. And one should go for early surgical decompression rather than delayed, as we already heard. The guidelines of the World Society of Abdominal Compartment Syndrome, and these are basically more or less used as a goal to see how to manage that, but it's not very strictly ruled that you have to go to these guidelines, because sometimes it's a clinical evaluation if you go for the abdominal decompression by surgery rather than wait for the measurement of the transbladder by transbladder technique. So sometimes you have to do individual decision making. So that would be it. Thank you for your attention.
So thank you, Shahzad. I think an important thing here is the key points. You have to see which patients are at risk who can develop such an acute abdominal compartment syndrome. You have to know their patients that you can avoid this syndrome. And the measurement of the blood pressure is only a diagnostic tool. You have to see the patient in all his matters. You have to see who is at risk, and you sometimes have also to decompress the abdominal wall if the blood pressure is under these 20 millimeters, for sure. And it's a diagnostic tool, and but it's also important. The faster this blood pressure is rising, perhaps you faster have to go for treatment, and also the severity of this organ dysfunction or failure. This the more aggressive has the therapy to be. Yeah. So, are there any questions for about this topic?
Well, thank you very much for this topic, which is important, not too well covered. I mean, I think we don't speak too often that. I think there are many cases that are underdiagnosed or end up to the wrong side and are not recognized. I think just as a comment, one factor is continuity of care also here, right? I mean, that's also today we have a danger, which we protect more the time of the doctor sometimes than the health of the patient, and that's certainly a risk, including ICU, where there is no continuity, and that's something we can miss. If you're really in charge of a patient and put your hand on the belly, I think, as you mentioned, before all these technologies, the clinic, the risk factors, and then we can intervene in this function. Do we have an idea about the incidence of this compartment syndrome, for example, here?
Incidence, no, it's not. We didn't get some data from it. It's difficult because there are so many risk factors, and these are the critical ill patients who can create this syndrome. And if you mentioned, if you see the patient at risk, you have to be on it. You have to evaluate regularly the patient, go for this diagnostic tools, and if there is an organ failure and the blood pressure is rising very fast, go for the decompression.
What would be the decision to close it? I mean, though you do a decompression, it's pretty aggressive surgery. You have to open the belly, let open, so there is no pressure. It's pretty obvious. If that goes in the good direction, when will you decide to close it again? Usually with a mesh, what we may do, but how do you decide this?
I think this is also an interdisciplinary discussion with the ICU. So if the patient stabilizes, if you can the flood recitation is, you can negative the balance, the fluid balance, and if you see that it goes in the right direction, then you can close it perhaps stepwise, and then you can see if you do first round perhaps with a bridging mesh. If you see it goes in the right direction, you can go every step, every operation, you go a little bit close the abdomen more.
Okay, good. Thank you.